Okay, so we'll just get started now, and happy Thursday, everyone. Thank you for joining us for this almost final masterclass. We're so thrilled to have our guest speaker here today, who will be talking to us about disability in sport. I will introduce her shortly. I just wanted to start off with a few housekeeping items and a special welcome. So I do want to say welcome to all of our attendees today, and for those that may be missing something, of course, you can always tune in on our website when the recording will be posted. We wanted to do a land acknowledgement as we do before each of our masterclass sessions. And so we acknowledge that this is sacred land upon which we are privileged to live and work. We recognize the deep connection and long-standing relationship between Indigenous peoples in the land of Southwest Ontario and of London, where we're situated. We acknowledge the Anishinaabe, Haudenosaunee, Lenapehoik, and Chinontan nations whose traditional lands we are gathered upon today, and we're deeply grateful to have the opportunity to be in this place. I'd like to mention a couple of housekeeping items as usual. We have turned off the chat and we'll be using the Q&A today. So if you'd like to put in some questions there, that's the place to do it. If you like somebody else's question, you can essentially like it, click it, and that will upvote it up to the top so that we will answer questions in that kind of priority sequence. The session is being recorded, and the introduction will be followed by a 40-minute presentation or so, and then we'll have about 10-15 minutes for Q&A. And the masterclass itself was developed with input from our scientific planning committee. So a big thank you to Dr. Eric Wong and Dr. Sadia Jain as well. So I have the distinct pleasure of introducing our speaker today, someone who's been inspiring to me for a number of years now. Dr. Catherine Carty is the UNESCO Chair on transforming the lives of people with disabilities, their families and communities through physical education, sport, recreation, and fitness. Her work focuses on delivering effective solutions for sustainable development and human rights through sport and physical activity. As a systems change expert, Dr. Carty collaborates with numerous international organizations, UN agencies, and policymakers on this agenda and continues to lead the movement to inclusivize, a word she coined and what I love, physical activity. So Dr. Carty, thank you so much for joining us. We're really looking forward to it. And as I mentioned, many people have a lot of questions in the space, especially as clinicians, in sense of what we can do practically when we encounter, when we're asked questions ourselves from patients about disability in sport. So I will turn over the microphone to you, and thanks so much for joining us today.
Thank you, Jane. I'm delighted to be here, and thank you to everyone for joining us, and also very privileged to be, although online, on this land in Canada. So really thrilled to be with you. So disability in sport is the topic indeed, and just a few disclosures of interest there in the first few slides before we get into the particular topic, and information about bias, and just some information about myself. As Jane said, I'm coming to you from a UNESCO chair in Munster Technological University, and our UNESCO chair leads on the inclusive policy actions from UNESCO, who is the lead UN agency with responsibility for sport, and obviously working closely with other UN agencies in that space, and in terms of physical activity with WHO, and human rights with other UN agencies as well, from UNDESA and OHCHR. But the objective of today's class, masterclass, is to look at being able to advocate for and support patients with disabilities in being physically active. So there's quite a lot covered in today's topic, but look, if there are particular questions you have, pop them in the Q&A, as Jane indicated there, and we'll get to them throughout the session. So a little bit of looking at the why first, why this is such an important agenda, and then what your role is and can be, and some suggestions for guidance for your patients. So I was involved also in the WHO 2020 guidelines on physical activity and sedentary behavior, where I chaired the subgroup on persons with disabilities. So we're going to have a look at what those guidelines say today, and take you through those, and the underpinning policy directive of the guidelines, which comes from a human rights perspective and sustainable development perspective, which again is to the why is this such an important agenda, and why should it be addressed in primary care and to your patients. So just looking at the importance of this agenda over the years. So I suppose we're looking first at the Global Action Plan on Physical Activity, which is 2018 to 2030 WHO Action Plan, which the World Health World Health Organization produced in 2018, and the World Health Assembly approved the Global Action Plan on Physical Activity, which is GAPA. And as part of that, they recommended that the 2010 global recommendations on physical activity for health be updated. So hence a group was convened to update those guidelines, and that's the group I mentioned earlier that we were a part of in producing the new 2020 guidelines on physical activity and sedentary behavior. But the vision behind GAPA was for more active people for a healthier world. And a key part of the mission was to ensure all people have access to safe and enabling environments and opportunities to be active in their communities, contributing to the development, economically, community-wise, health-wise, cultural, social development of all nations, and to achieve a 15% reduction in physical inactivity in adults and adolescents by 2030. So that was the goal of GAPA, and then it was a case of renewing the guidelines so as the development was on the basis of the most up-to-date evidence that we had available on physical activity for different population groups and the general population. Underpinning GAPA and actually every physical activity and sport international policy since 2018, 2017 actually, has been the Sustainable Development Goals. And you may have heard of these goals very much embodied in policy documents across nations at the moment, where every country reports periodically on their progress. But, from a health perspective, you can see there SDG 3, good health and well-being. And I suppose the one most closely aligned to what we're going to talk about today is Target 3.4, which looks specifically at reducing non-communicable disease and improving mental health as well, where physical activity, sport has a role. But indeed, the input and impact of being physically active spans 13 of these sustainable development goals, by some analysis, 10 by others, but it pans many of them. So when you create opportunities for people with disabilities to be inactive, you're reducing inequality, which is SDG 10. It can contribute to decent work and growth, which is totally different, and sometimes one that we don't think of, that by creating opportunities for people to be active, yes, we impact their health, but we impact across other social and economic indicators as well. So it has a large impact on people's lives. So GAPA and the WHO Constitution enshrines health and being healthy as a fundamental human right. And in Agenda 2030, we look at the implementation of this action plan employing a rights-based approach. So the opportunity to be physically active is part of a human rights-based approach. And we see now in health policies across the world, the predominant paradigm of care is transitioning from a medical model to a rights-based or social model, or intersection between human rights and social model in care. So this provides an impetus for us to really look at the human rights of people, including those with disabilities, and making sure that when we plan for physical activity in our communities, we're planning for everybody who has the same right to access to physical activity and sport. This is the particular SDG I mentioned, SDG 3, good health and well-being, and the target 3.4, which points to reducing mortality from non-communicable disease and promoting mental health. And today we're going to focus on how physical activity, sport, can contribute to that reduction in non-communicable disease in many different ways, by looking at the physical activity and musculoskeletal health areas, and also looking at promoting mental health. But one of the key priorities of the Sustainable Development Goals was that we look at those furthest behind first. So who are we not providing for? Who do we not prioritize when it comes to planning for sport and physical activity in communities? And it is often those with disability, and within that disability category, where it might be physical disability, sensory, psychosocial disability, intellectual disability, etc. So they're often the furthest behind first. And what WHO are asking for is proportional university, invest our greatest resources and time to those who face the greatest barriers to participation, and that they should be a priority. So very much people with disability are among that group who we are being asked to prioritize in our efforts to level the playing field, to address the needs of those furthest behind first. And the idea of that within the sustainable development context was, we cannot say we're developing as a community, a society, a nation, a profession, if we are choosing to leave people behind through our action or inaction. So very much a call for us to look at who's left behind and how can we put attention on those cohort groups so as they're no longer left behind in what we're doing. And this is not just in WHO policies, we see it in UN General Assembly resolutions, we see it in UNESCO's Kazan Action Plan and other areas. Actually, as I mentioned before, every international policy in sport and physical activity has prioritized this agenda since 2015. And increasingly that's spreading from the international level to national, to regional, to federation level as a priority. Now, this shows the intersection of different policy agendas, including even like from the Olympic Charter, broadly human rights agendas. You know, there is this commonality across many of them that converges on human rights agenda and sustainable development and the need to address the priorities or the emphasis on those left furthest behind. Obviously, human rights agendas have been around for a long time. It's actually the 75th anniversary this year of the Universal Declaration of Human Rights. So we have shared the same human rights since 1948. But we're seeing in the last few years, especially in the last decade, a shift in emphasis onto a human rights-based approach in these areas. And that is threading through into, I mentioned health policy, but very definitely into physical activity and sport policy in the last 10 years, and very evident since kind of 2015 and the emergence of the Sustainable Development Goals. So it's given a new emphasis, a new rights and new priorities on making sure that we address the needs of those who have disability in our community. So on to the guidelines. So these are the 2020 WHO guidelines for physical activity and sedentary behavior. And these were to provide public health recommendations on how much activity people need to do, what type of activity children, adolescents, adults, older adults, and subpopulations that were covered were pregnant women, those living with chronic conditions or disability, should do for significant health benefit and to mitigate health risks. So they're the new guidelines. You can see since the 2010 guidelines, the specific conditions were added and sedentary behavior was added. The primary audience and user of the guidelines are policymakers. So there is an ask and an exercise in translating the guidelines to communicate them to the public and to communicate them maybe to population groups that you might be targeting within a cultural context, or for appropriate language versions, or just, you know, to be relevant in a particular setting or for a particular subpopulation group. So in 2020, WHO produced these guidelines for physical activity and sedentary behavior, and they became the first global guidelines for physical activity and sedentary behavior for people living with disability. And they're evidence-based guidelines, and they were urgently needed considering rampant exclusion of people living with disability from nearly all sectors of public life, including healthcare, sport, and physical activity. So there was absolute consensus that we can't keep going without having a global set of guidelines to address the needs of those living with disability when it comes to physical activity and sedentary behavior. And WHO produced some very nice resources, including a video. This video I'm about to show you, which is the particular one for adults with disability. It's an accompanying one for children. But these videos are really useful resources that you could show in your practice, in your clinic, on your social media to emphasize. Remember, raising awareness is one of the starting points of getting somebody, triggering somebody to become physically active. Showing imagery of people with disabilities being active and involved in physical activity in their community. So sharing resources like this is the starting point of showing that this type of activity is important for people. a strong message there from WHO. Everyone can be active. And the other key thing in that is every move counts. And they're quite different to the previous guidelines. In the everyone can be active is critically important, because we do know that there are a lot of myths out there around the importance, or the how important physical activity and sport are for people living with disabilities of different types. And so it was very important to get the message out there that physical activity is for everybody, and that everybody should be involved in, or should have the opportunity to live a physically active lifestyle for health benefit, and that there are no myths around that, or that we can quash myths that do exist. And the myths are coming from different sources. So sometimes evidence supports the fact that parents are sometimes overprotective of children with disabilities, and impact the reduced level of physical activity that their children are engaged with. So it was very important to dismiss some of these myths, and that was a part of the purpose and remit, I suppose, of what was being done. And another key outcome that I think for those living with disability was critically important was evidence is pointing to the fact that every move counts. And this was different to the evidence base when the 2010 guidelines were being developed, whereby there were recommendations around bouts of physical activity and cumulative bouts of 10 minutes plus. But for some people, especially those living with disability who are sedentary and just beginning on a journey of being active, the message that every move counts is critically important, because it enables people to get started where they're at, where they're comfortable, and to know that there are health benefits to be gained from doing that, from moving away from sedentary behavior to beginning to build a pattern of physical activity in their day-to-day life. So that every move counts message was critically important. So there were messages for different population groups developed for the first time. And in the case of children and adolescents and adults living with disability, the evidence was drawn from the population groups that you see listed on the slides. So we did look at specific population groups in terms of the volume of evidence and what they were saying, but we also looked at the evidence from across the general population groups and looked at extrapolating data from those as well, where it was relevant to those living with disability, both from the children and adolescent population and from an adult population. So the guidelines were then developed, and here you can see the guidelines for children, looking at 60 minutes per day, and the specific benefits. So that in children and adolescents, physical activity confers benefits and health outcomes, including improved fitness, cardiometabolic health, covering blood pressure, dyslipidemia, glucose, insulin resistance, and bone health and cognitive outputs, and also reduced adiposity. And so at least 60 minutes a day, cumulative on at least 3 days a week, vigorous intensity aerobic activities, as well as those that strengthen muscle and bone. So that was very much emphasized there. And the strength of the recommendation you'll also see referenced, which is the degree to which the guidelines development group were confident of the balance between the desirable and undesirable consequence of implementing a recommendation. So not only were the thresholds given in terms of how much activity should people try and do across the week, the strength of the recommendation is given there, and some guidance on the different types of activity that people should do. In addition, sedentary behavior was quantified at the recommended guideline in relation to sedentary behavior, and children and adolescents living with disability should limit the amount of time spent being sedentary, particularly the amount of recreation screen time. You will notice that the recommendation for children living with disability and for children and adolescents living with disability and those not living with disability are the same in terms of the actual guideline. And that is what the evidence was there to support. And we think that sends a really positive message. But what was acknowledged and is important is that the good practice statements. So even though the guidelines are the same for everybody, good practice statements are critically important in beginning to design or prescribe or develop an exercise and physical activity program with your patients and with your clients. So the key message here is that doing physical activity is better than not doing physical activity. And that in itself is an important message. Plus, Separately, evidence points to us that messages coming from doctors to their patients around the importance of physical activity are critically important. They impact the behavior of their clients very much. And the idea that every contact counts with your patients, and mentioning, whether or not somebody is engaged in physical activity is critically important to that person beginning to think about becoming physically active. And then you've got your good practice statements, which will help you give sufficient information for people to get started. So doing the activities is better than doing none. If children and adolescents living with disability are not meeting the recommendations, doing some physical activity brings health benefits, and that's back to our every move count bits. So even those who find it really hard to get started, not sure on what to get started, there are health benefits from that phase of beginning to get active. Children and adolescents living with disability should start by doing small amounts of activity and gradually increase frequency, intensity, and duration over time. There are no major risks for children and adolescents living with disability engaging in physical activity when it is appropriate to their current activity level, their health status, and their physical function. And the health benefits outweigh the risks. And that's a very important message. And it's not just parents that sometimes protect their children thinking that maybe this is not for them or whatever it might be. It is critically important to point to this fact that the health benefits outweigh the risks. Children and adolescents may need to consult a healthcare professional or other physical activity and disability specialist to help determine the type and amount of physical activity appropriate for them. And thankfully in the community, we're beginning to see more physical activity and disability specialists operating who can guide somebody as to what type of activity they might like, they might enjoy, and how to get started with that activity. That's new as well in terms of pointing to a physical activity specialist as somebody to guide people in their physical activity journey. Actually, due to time constraint, I'm not going to go through this video, but it's the same type of video as the last one I played, but specific to children. And Jane will share the slides with you, I'm sure. And when you get these slides, I would encourage you to share these videos on your social media, or, many of your practices, I'm sure, have screens. Show the screen. You're sending out a very strong message to your patients and family members of patients and others who know children with disability in their community. It might be a sports coach sitting in your clinic who sees the video and says, gosh, yeah, what are we doing for children with disabilities? So very important to see the messaging out there, raise the awareness that this is important. It's easy to get started. You can see people doing organized sport and just activities of daily living in those videos. So in terms of adults living with disability, again, here we see that all adults living with disability should do, and again, same guideline as the general population, 150 to 300 minutes of moderate intensity aerobic physical activity, or lesser if it's vigorous physical activity, or equivalent combination throughout the week for substantial health benefits. And we also see here the reference to muscle strengthening activities at moderate or greater intensity, 2 days of the week. And these being very, very important. And indeed, 3, varied multi-component physical activity that emphasizes functional balance and strength training at moderate or greater intensity. And that's your musculoskeletal disorders as well, and that affect a large percentage of the population at the moment. I think it's 1 in 2 adults over 18 and 3 in 4 over 65 affected by musculoskeletal diseases and disorders at the moment. So they're very common. So making sure that we look after multi-component physical activity and muscle and strength activities, as well as balance, agility, flexibility, being very, very important. So they are what the guidelines are stating for us, and very strong guidelines there in terms of what it's saying for people with disability as well. But the good practice statements being critically important in making sure that people start at a level that's appropriate for them. Okay, so then on the sedentary behavior, again, it's recommended that adults with disability should limit the amount of time being sedentary and replacing sedentary time with physical activity of any intensity, including light activities, to provide health benefits. That's a very strong and important message as well for people living with disability. And, I think that getting that message across. So physical activity and sedentary behavior as well being seen somewhat separate. So yes, get in your physical activity. And, there's only so much time in the day people are physically active, if the rest of the time is spent in very sedentary behaviors, that has an additional negative impact on our health. So breaking up sedentary time is also important and quite different to, I suppose, designing and prescribing or looking at how people can be active, but how can you just break up that sedentary time as well, and getting additional health benefit from that. Okay, and again, here we have the good practice statement for adults, not overly dissimilar than the guidelines for children and adolescents there, but the good practice statements give you a strong starting point and confidence to get started, that you know, with your patients can give good quality advice, even if it's at this level. And we do know that people listen to this advice and act on this advice. And there's a lot of behavior change theory behind getting people active, and giving these messages and even showing those imagery in your clinic will send out that strong recommendation to people. So yes, again, the sedentary behavior guidelines and recommendations were based on the general population evidence, because there were gaps in the evidence when it came to people, both children and adolescents and adults, and disability. So the supporting recommendations or the supporting evidence and rationale came from the general population, and there are gaps in disability space that we need to fill. And we call on the research community continuously to try and look at those gaps and build up the evidence base around disability. But the scientific base was there enough to support the guidelines that are developed and recommended and are in the current 2020 guidelines for physical activity. And we know, you know, there's quite a wide range is mentioned there in the guidelines, and that's where they're sitting. And obviously, as you know, people increase levels of physical activity well beyond the ranges, the risk and harm increases. But within the recommended ranges, we have a confidence that risk and harm is reduced, bearing in mind the safety statements. So they're the guidelines in summary. And how did we develop these, I suppose, and what was the importance of them? So the group was established. We reviewed the scope of the guidelines and agreed the PICOs. We reviewed what was developed in the States in the earlier guidelines that they had developed, and built upon that with a comprehensive evidence synthesis, and updated what was done from previous guidelines, and looked at the quality of the evidence there. We produced draft guidelines and had extensive public consultation on the draft guidelines, and got a lot of feedback in from that, nearly 500 kind of feedback submissions coming in from that process. And the guidelines have to follow a very defined process in accordance with the WHO Handbook for Guideline Development, which is across the whole range of guidelines that are developed. In addition to the evidence and the quality of the evidence which was assessed, we looked at a range of other parameters. The benefits and harms of the guidelines in and of themselves. Equity and human rights came in again, and very important. The feasibility of implementing the guidelines, the values and preferences of the target cohort groups for the guidelines, resource implications, the acceptability of the guidelines to the target groups and population groups as well, and the priority of the problem. So these factors were all considered in deciding the guidelines and to have the guidelines and the strength of recommendation, etc. And they were critically important, and at all levels there, it was deemed to be important that these guidelines were developed and communicated. So then there is a process that, beyond, I suppose, the production of those public health guidelines, these are international guidelines, and sometimes countries want to establish their own guideline, and they have indeed their own guideline development process in place, or they might want to adopt the WHO guidelines, but look specifically at their application within a particular part of a country or for a particular subgroup within a country. And there are a number of mechanisms at place for this. And indeed, a number of countries have gone down this route to develop guidelines. I was involved with a group in Australia who looked at the area of brain injury and establishing physical activity guidelines for those with brain injury in Australia, for example. So you have got a process of adultment or valorization that can be done to adapt, adopt, or develop de novo new guidelines for particular population groups, and there are processes around with that. But we have very strong guidelines, and we are very clear that the guidelines mark a purposeful and positive step around including people with disabilities in mainstream sport and physical activity initiatives. The lack of evidence, yes, we're calling for more evidence all the time, obviously over time, but the evidence that exists enabled us to produce those strong guidelines and to begin to change practice on the basis of those. But where we want to get to is where designing activity programs, prescribing for those with and without disabilities becomes mainstream, that we do this as, all the time. But we have to raise awareness. So in terms of what can you do, raising awareness constantly with your patients is important. Communicating the benefit and the value of being active is important. And we know how important physical activity are in general non-communicable disease, morbidity and mortality statistics, as well as into the musculoskeletal disorders and effect. And, it's really common to have these disorders. So very important for this. We have to look at our environment, at how we train people to work with people with disabilities, partnerships. And again, this is something that you could potentially do. So there's lots of people are willing to work in partnership to support people with disabilities being more active in their communities. And that's a way to go. More research, the human rights programs, and making sure that we enable people to access their rights, including those with disabilities, have programs, invest in it, and have good governance that includes people with disability in the planning and design and implementation of programs. So there were some of the things that we did. And then pointing to some guidelines and resources that we have. So disability is a huge area, obviously, and there's lots of different aspects of disability for which providing advice and guidelines to your patients is, might seem, given the breadth of areas of disability you might have to cover, it might seem somewhat overwhelming sometimes in terms of how do I begin designing exercise programs, whether it's for spina bifida or cerebral palsy, or someone who has a visual impairment, or someone with intellectual disability, or whatever the condition may be. But we have designed a program called UFIT, and you'll find it online on justdoufit.com. And we also have an app. I'll point to some of the resources here. And the idea behind UFIT was to enable fitness centers in a community to offer, health and fitness opportunities to people in their community. But we've actually developed a suite of resources that are just as applicable in a primary health context, or, for patients that you might have, for people within a hospital setting or other settings, to begin to design exercise programs or prescribe exercise for people. We also know that some people like to begin their activity journey at home and get a little bit comfortable with starting out things at home before they go into another environment, like into a community offer that might be out there for them, or into a gym environment. So our UFIT program, if you go online, if you go onto the UFIT site, you'll be able to register, and you'll be able to access a whole ton of resources when you register. But even without registering, there are plenty of resources there. And registration is free, and the resources are free. But there are things that you'll be able to find here that will help you in guiding your patients towards how to begin being physically active at home, and based on good advice, and also things that you can look at to, to kind of look at how to design programs for people with specific needs. So this is an open repository of inclusive activities and exercise sessions for people with disabilities and chronic conditions. And there are some live sessions from time to time as well. But we have a whole range of resources, some described in a resource called UFIT Explorer, which I'll come back to in a minute. On what that does. And this is specific exercise for specific conditions. And we'll have a look at that in a minute. There's a UFIT app, which you can have obviously on your phone to give you access to this content very quickly, very easily, and in a way that you can share maybe with patients as well. We have an audit, but this is more for facilities, recreation facilities. How accessible are they for people with a variety of different disabilities? We have links with the American Council of Exercise, and have a portal on there to help with courses and professional development if you wanted to develop our access certification in this area. We have our home exercise repository and the online course that we do in terms of resources. So we have some resources from Special Olympics as well, obviously specifically focused at those with intellectual disability and developmental delay. The American Council of Exercise Library, again, obviously the American Council of Exercise run a whole series of certification programs and whatever else. This exercise library are specific exercises that people can begin to try at home with all the safety guidelines as well. And we do know from people that a lot of people like to get started on their journey at home. Some prefer to go to a club environment or some other route to start their exercise program, but there's a whole bank of exercises here that you can link to. NCPAD is the North American Center for Physical Activity and Disability as well. They have a huge amount of resources. You can click into them from our UFIT site and see the resources that are there, engage with them. Again, they're for people with specific areas of disability. There are lots of video clips, suggestions, good practice statements, research articles linked there. We have a whole group of exercise for older adults and those with limited mobility, and some videos from a few organizations there as well that have just produced good quality online content. Okay, and you can see that there's some for all older population, adults, children, some other languages. I think there are some French groups in there, dance and Paralympic resources. Then onto our UFIT Explorer. So this is where we have produced a whole battery of resources for specific conditions. And this battery of resources is growing all the time. And when you click into any one of these on the website, it takes you to a specific range of questions. So you can see there are some of the conditions that we've developed information for so far. And what we have are, for any of those conditions, we give a description of the condition, the implications for exercise of that particular condition, links to the medications that people may be on based on that condition and the implications for exercise, facilitators to participation. So how do you get over the barriers that people maybe normally have, or what are the indicators of the time, modifying the instruction, modifying the movements, environment support for people. What are the current guidelines, the American College of Sports Medicine based guidelines on actually designing that aerobic training program or resistance training program? So whether you're looking at the aerobic fitness or musculoskeletal area, some guidance in there for that specific to the condition. Sometimes we have some additional categories in some of the UFIT Explorer guidelines, but each of those conditions has a body of information attached to it. And we know that when we spoke to people originally around disability inclusion, what do you want to know? You can imagine if you went through every one of those conditions all at once, it becomes overwhelming. So the idea was that, you might have a patient come into you who has multiple sclerosis, and you want to know specifically around that. Well, go to that resource in our UFIT Explorer piece, and you'll see everything that you need to know in terms of giving that person advice. You can click it on our app, you can click it on our website, you can direct them to it. So this is clarity of what needs to be done. In addition to that, we have some case studies like that in the UFIT Explorer resources. So here's Max. Max is an 8-year-old boy who uses a wheelchair, and it takes you through what the story is for Max, like what does Max wants to do. So we look at some case studies there and how that might be, how you might direct somebody like Max who might come into your client. Sarah has her eyes set on Olympics or Paralympics, so Max wants to engage in community sport. So how might you direct both of these people who live with cerebral palsy in your community as to how to become physically active and what resources you can look for? So there's some of the things that the UFIT resource takes you through, and there are a ton of resources from the very basics of the condition into a particular case study of an individual and into the specific exercise prescription guidelines for that. But, bear in mind that often when it comes to disability in sport, your client is an expert or your patient is an expert on their ability and disability. So they will often, they are a guide. So the idea that you have to know everything and be expert at everything is one that you should really maybe get into a co-design space. So we design programs with someone with a disability. Obviously, there are clinical practices that you need to be aware of, and we've covered some of those within the UFIT Explorer guidelines. But negotiating, like ourselves, you know, what type of exercise do you want to do? Which exercise and physical activity do you find fun? And are you therefore likely to keep up, are critically important. In a Canadian setting, the Stedworth Centre at University of Alberta produces some very good resources as well, and as does the Abilities Centre. And I know that there are a few Abilities Centres within Canada as well, and they do some good research and impact activities there through both of those centres. And actually, Jen Leo, who was working with us at the UNESCO chair for a while, she came from the Ability Centre and went back to Canada, and then is now currently working at University of Alberta in the Stedworth Centre. But I'm very aware of the resources that they have developed there, and toolkits and supports. So they are also a very good resource. But where are we at? Sorry, back a little bit to the why do we do this, and how do we do it? And conscious that you, in your various different roles, both, you know, working with your patients, but also possibly a lot of you are working at policy and advocacy level as well. We know there's gaps in physical activity, in the global status report on physical activity, significant gaps in policy implementation. So while we have new guidelines now, while it's a policy priority, we're not seeing it translate to practice. And there are 5 reasons for that: political, technical, financial, collaboration, capacity building, and data systems. So effectively, we're not seeing the results delivering on the ground from, I suppose, the work that was done at the level that we need, and especially as you go into populations such as those with disability. Sometimes we think that it's, you know, a lot of sports clubs will say to us, and activity offers in the community, well, we're there for everyone, but they're not coming to us. And for some population groups, and especially those with disability, and maybe you can see it as well with Indigenous population groups in some countries as well, where there are just more barriers that people face in becoming active. And a club or a service offer, a health club in a community or a community recreation facility, while they might say we're open to everyone, sometimes you have to reach out to these communities, and especially those with disability who may not perceive that physical activity or sport is for me. You have to make an extra effort to reach out to those and say, no, we're going to invite you in. And that's beginning to be sensitive, an increased level of awareness that, you know, we need to reach this population group. So we have to, I think we're at the point of being a little bit sensitive to this now, but we actually need to move towards being responsive and intentionally target specific groups and highlight the benefits to those specific groups. And this in your clinic might say, or in your practice might say, begin to put up a little bit more information that, do you have a disability? Physical activity is for you, you know, is for you too, or whatever message you want to say. Use the guidelines that are developed by WHO, show the videos in your clinic, and get the message out there that this is something that's for everybody. And where we want to get to is a point that's transformative. We want to transform the system so as this is mainstream offer and not a niche offer. And this is what I'm talking about in shifting the dial and bringing us to that human rights space where we reduce the causes of inequality, and our strategies support everyone in being active. And if you think about your pre-vocational training, you know, how much physical activity did you cover? How much sedentary behavior did you cover? How much disability and physical activity did you cover? So, you know, we may need to move to a place where this becomes mainstream, that we look to prescribe for everybody. There are a few very good research articles out there as well on prescribing exercise as medicine. There are different terms used in different places, and lots of people have different views on them. The main point is we need to get everybody active, physically active. And here's a review of general practitioners and patients, recently produced as well, very good review, prescribing and dosing exercise in primary care, and is current medical training preparing physicians to prescribe exercise to their patients. So different perspective, different views in research articles coming out. But the good thing is there are lots of resources out there. I'm going to speak briefly, and I'm very conscious of time, but one area that we're focusing in at the moment in the work that we're doing in the UNESCO chair is looking at mental health, and mental health is psychosocial disability. So, and you saw we have a UFIT Explorer resource, which we're actually currently updating on the area of mental health as well. So when we're talking about empowering recovery, we're talking, if you look medically, we're looking at conditions like schizophrenia, bipolar disorder, and other psychosis. And we know among this population group that there's a 15 to 30 year lower life expectancy. And it's predominantly as a result of the physical health consequence, I suppose, of living with a mental health condition or difficulties. And where often the physical health consequence can get neglected to a certain extent. And that is the factor that contributes to the 15 to 30 year lower life expectancy, as well as the impact of having that condition and maybe the medications that go with it and the condition itself. So there are challenges. But we want to, what's been asked for at a UN level and at a global level is reframe treatment, go to this recovery model. It's a much more holistic model that looks at lifestyle-based interventions in addition to the traditional approaches that were used in terms of pharmacology and psychiatry and psychology, etc. But to build in physical activity, nutrition, and we're looking also at the digital technologies, and I'm talking about like everything from your Apple Watch, Fitbit type thing to, you know, using digital in different ways around this area. But we're looking at that to have this multidisciplinary approach and to have that connection as well to people, to physical activity and to life in the community. So the social dimension, and this is one of the things we're finding in the research, that it's not just physical activity like do this particular piece of physical activity. It's physical activity that has a social component attached in their community. And that's taking the person out of the mindset as well of, you know, this being just treatment, but this is part of my lifestyle, of me and my community, doing things that other people in my community do as well. So it's integrating that into this holistic paradigm of care that has a shift away from the pure medical model into a social human rights model and approach. And that very much being aligned with where all the policy objectives are at the moment. And we know that that approach delivers a lot of positive results. The Lancet Commission report on that backed that up in 2018, 19, and there's a new iteration of the Lancet report coming into place early next year that will focus on physical activity interventions in that area as well. So in this space of mental illness, which is psychosocial disability. So again, into that space as well, which, you know, some people don't maybe identify as in the disability space, but very much so, and very much connected with the other areas. I mentioned these already, and these are the barriers to practice change that are in place. And there are lots of things that you can do, you know, as a doctor to get over these things. So in summary, the guidelines are there. They reflect the commitment to inclusive action. Every country in the world who's signed, members of WHO have signed up to this agenda to increase this. We know that at the policy, regulatory and statutory level, there's a consensus. We need to prioritize this, but at the practice level, the more we can do, the better. Practice is lagging behind policy in this space, and we really need to build it up by prescribing, and that starts with, you know, raising the awareness. Everyone, multiple stakeholders have a role to play, including primary care professionals, in co-creating the inclusive environments, and that's critically important. It's not all on your head. Sometimes people don't get started because they think they don't know enough. The first conversation you might have in your community is in linking out with a disability group in your community, and link up with someone you're happy to get started with. If it's intellectual disability, or if it's your local Special Olympics group or Paralympic group or cerebral palsy sport group or wheelchair sport group or a mental health group, link up with that group and begin that co-creation process. And you'll find that by working together and working with those living with disability in your community, your knowledge will grow exponentially and you'll become more and more comfortable within the space and learning from each other and delivering very important, impactful health outcomes for those people. So I would say start by making every contact count. So even, you know, whichever patient comes in with whatever level and area of disability, we know evidence supports that physical activity is important. You have your good practice statements to enable you start confidently, and you have the deeper dive knowledge through the UFIT resources, ACSM resources, and others. one intervention can, as in physical activity, can have so many potential positive impacts across cardiovascular health, non-communicable diseases, musculoskeletal disorders and diseases as well. And so, physical activity is a really good, identified best by WHO, and it's one that you can promote by just recommending to people and then getting further into the kind of designing with and for. It's in line with human rights approaches to health that are the predominant approach globally, and where every, I suppose, policy directive is, we still need to shift from a biomedical model towards this much more holistic, integrated model of care. Just Do You Fit resources have resources and advice, and there's contact information there for us that you can contact on specific needs that you don't find access to on our website. And these resources are constantly being updated and developed over time. So absolutely encourage you to get involved with us on that. And that brings me to the end of the formal part. So I hope we have sufficient time now for some Q&A.
Thank you so much, Catherine. That was outstanding. It just hit every single point. I think that from a practical standpoint for clinicians, I wanted to highlight a couple of things that really stood out for me in your talk, because I think one of the major takeaways for people here, for clinicians, is really how do you get started? And I think, to your point that we don't have a lot of training on physical activity prescriptions or counseling in Canadian medical schools in general. That's changing, thankfully. It's been changing probably over the last decade or so, that people are starting to get an appreciation for it. But I think it's that that barrier of even beginning the conversation, either from a lack of training or aspect of, or just understanding, is there something that I might be missing, like something liable, or could I be harming patients in the sense of talking about physical activity? And I think what you've done really, really nicely there is bring to the point that it's really normalizing the conversation, get started, and there's multiple resources to help you begin the conversation with patients. And that's been really outstanding. It was very clearly laid out for us. I want to thank you for that. I know that someone's asked already about the questions about the link. And as you were talking about the Just Do You Fit, I just was just kind of glowing in the sense of, like, this is perfect. This is exactly what we need, right, in this space. Because I think a lot of people, I mean, obviously, as you've said, that there's a whole range and variation in terms of what that looks like for patients with disabilities and how to get started. And there isn't kind of a one size fits all, as we know with any of our patients, right? But particularly if we're trying to understand barriers or lack of resources and supports in the community. Someone has asked for the link, and Kristen has put that in the chat. She's also put in the evaluation form that's already there as well for afterwards. But if you want, for people that want to check in, I know I just started putting it already in my browser, and it looks fantastic. I might just start with that question in the sense of that resource tool. I mean, obviously it's great for clinicians, patients alike. What's been the response so far from the community once that's kind of put up, from your perspective?
So, right. So actually, we did have a Canadian launch a few years ago of Just Do You Fit directly, but I think there were changes within the industry body at the time, so it has been a little bit slow. But in terms of the resource, it's been really useful. And the approach that we recommend, and you'll see as you go through the resources, is this partnership approach. So, we do find that, I guess, from the perspective of your doctors, health centers, linking up with others in the community. It's about signposting to each other. So what we get the others to do, you might find that there's a willing club within your community or a setting where you can refer patients to, and it mightn't be a formal like exercise referral program, but that there's something on offer in that center. We have the resources to train the staff within that. And you'll often find that there's a staff member who has a particular interest in, cerebral palsy or spinal cord injury or whatever it might be. And they can build the expertise in that area. But what they find is they get very comfortable with it. And we've also found that the sites who offer this type of activity, including people with disabilities in what they're offering in their health club or fitness center, it's had a very positive impact on the center. It has an impact on the retention of staff. It has impact on their membership. You know, it in general, there are multiple positives to come from it. And people with disabilities and their families will actively bypass other clubs to go to these clubs where they know there is this interest in and provision for those with disabilities. We know that sometimes regulation dictates that you have to have accessibility at certain levels and in certain areas and clubs. But if that's not seen by those with disabilities living in the community, they don't tend to go there. So I guess for doctors, being able to have those partnerships that you can refer to, obviously for you to say to somebody, you know, I'd encourage you to get active. It's easier if you can say, yes, you can do something at home, you can do something in the community. It is easier if you can have confidence that you can point someone to a particular place that you know someone's doing something in that area. So local partnerships are important. And in our experience as well, we brought in the advocacy groups, the NGOs, the civil society organizations, like some of the ones I mentioned, like be it a Paralympic group or a Special Olympics or a cerebral palsy group or an intellectual disability group, and have them as part of it. And the learning that everyone shares in that context is huge. But don't wait to have 50 million nuts and bolts in place to get started. I think if, a doctor in their clinic, someone comes in with a disability, you can get started in that journey. And if you look at behavior change theory, sowing the seed is step one, and somebody beginning to identify that this is something that I should be doing and that this is something that's for me. Moving from that stage into the action stage takes that little piece of time, but beginning to get the messages out there, the perception is an important part of that change process. So get started, and then how you get on that journey and how far you as a clinician can go, because people are busy, how far you can go yourself before you just need to let somebody off to someone else in a health center who'll take over and who'll bring that person and design a program with them that they can continue on. There are different ways in which some people continue on it. Some people can sign off to someone they're confident will look after their patient. And they hear back from time to time, either from the patient or from the club. And so there's various arrangements of that have taken place in different countries. So we've offered this program and ran it in different countries. And it is a successful model that works and that people are comfortable with.
That's fantastic. I know everyone's going to be checking this out, which is great. So we'll be certain to certainly signpost it. As we mentioned, we have the link in the chat there as well. And I do really like one of the other takeaways for me during this talk was also understanding that moving away from the medical model. I mean, even as a healthcare professional that wants to counsel exercise, in one sense, the use of the word prescription, not so much towards patients, but maybe in a sense of legitimizing it within our community, the medical community, and saying, hey, this lends credibility. But even with that in mind, I like how you've said about moving away from that medical model, that really this is human rights-based model. And that I think that really resonates with me as well as someone trying to advocate in this space, that it's not just about saying, hey, we're here to treat your condition, but really this is, you have a right to participate and you have the right to access. I'm mindful of time. We have 1 minute left and we have one question left. So I'm just curious, Catherine, if so one of the attendees has asked if that the guidelines that are accounting for the support of family members and peers for people who are interested in starting an active lifestyle. So I think what that's getting at is for the people that the support people, family members, peers, would they still follow those same guidelines, or do you have any specific advice for them in that context?
Yeah, I mean, we designed the resources so as they could be usable by people living with whichever condition or disability, professionals working with them, say fitness professionals, but also for carers. And there are some videos. We've developed some videos for family members and carers as well. There's videos there about communication. There's a few different types of videos there addressing different topics. But Yeah, the whole families are critically important. You know, this whole idea of no one's an island. I mean, we know this, but families make decisions on physical activity on the basis of somebody within the family who has a disability and whether or not they can participate in things. So it's critically important that the family situation is taken into account. And often
Yeah.
people with disabilities are reliant on family members for transportation and for other things. So choices around what type of activities people are going to enjoy and participate in are led by families. Also, how important physical activity is for an individual with a disability can be influenced by family members, whether that's a parent or a sibling or someone else, depending on the age and stage of the person and nature of the disability. Families are important. So it's if families don't accept that being physically active is important for their family member with a disability, they're not going to be supporting them in being active. So they need to know as much as everyone else. And we have examples where family members in the past have been the one culpable of saying, you're dealing with enough. You don't need to try and integrate physical activity as well. That has happened. There's a whole move towards more risky playgrounds for more risky play for people with disabilities, because we've got to a stage where sometimes there's people in cotton wool and not encouraging people to be active, which is actually impeding their health development. And in terms of rights, it's also the right to health, the right to the highest attainable standard of health. And we know that being physically active and reducing sedentary behavior helps you get access to the highest attainable level of health. So apart from our rights to be physically active, it's about all our, I suppose, responsibility around ensuring that patients and those patients have access to the highest attainable quality of health. And that includes giving people access to opportunity to be physically active. So, again, it's why I would encourage having that as part of the every contact counts. So even if you're not, you don't have time to start setting up partnerships with community groups, but you do have time to say to someone when they walk into your clinic, are you getting some physical activity in the week?
Exactly.
And that sows a seed and that changes behavior, and research backs that up. So if that's your starting point, start there. And they might come in, 2 or 3 months down the line or 6 months down the line and say, you mentioned physical activity, do you have any idea? Or they might mention something about it, but it's very important to start sowing the seed.
That's brilliant, and you can tell the passion that you have, and just and so clear and coherent, and I love it. We're thrilled to have you. I think we'll have to leave it there for time because I know people will be on their way. We've gotten some nice thank yous in the chat. For those, thank you all for joining today. I know people have to trickle out. If you you will be sent as an email containing a participant evaluation survey tomorrow, so please take time to complete that survey. If you need a certificate of participation, you can indicate in that survey and you'll get another link, and so that your evaluation remains anonymous. And please email us with any questions or concerns. We have one masterclass left plus a bonus. But I'm just, people, I love this session so much, Catherine, because I think it's so practical. We have something that we can use right from today with our patients. And you've really, I think, demystified a lot of these conversations.